I want to go to synapse. So let me pull up an image and then we'll start with the image so we can go over some definitions again. Then
Oh, contact is changed.
it's changed.
Contact is changed to shell. But resident information is not changed.
Okay.
So it's still, I think the news is still Joe. Yeah, Joe's class.
Joe is what?
Like this is still, we only update until 2015, 2016. So we missed 2 years.
We have to like delete all this part of it.
Right. It's pretty.
No, it's not that. No, this part of the video is recorded already.
Oh, it is recording. See, that's the thing. That's that part. I don't know what you're going to do.
Yeah, yeah.
Sorry, I had to pull up.
No, it's okay. I'll just edit it out.
Okay,
I'll
you
cut it out
can.
once it's like finished.
You can do that.
Yeah, yeah.
Can't seem to find 10, 12, 87. Can't seem to find the patient that I want to discuss. Let's get.
What about that patient that we saw last month?
Which one?
It's a guy.
Oh, you mean in the clinic?
Who's the patient that saw Dr. Gettings?
Oh yeah, yeah. He was pretty advanced. Yeah, no,
Yeah,
this
he
one
was-
I just want to get a case scenario for you guys. So that... All right, so this is the case. Okay, so this is a 35-year-old female who comes to you saying, my brain, I had a brain MRI because I had headaches, and now my doctor tells me I have MS. You go through the history, you ask for elaborate history, going through a history of vision loss, gallbladder symptoms, motor symptoms, sensory symptoms, cerebral symptoms, none of that. Okay, she doesn't have any symptoms in the past, no vertigo, double vision, dysarthria, no brain symptoms. So you go through the whole sequence, but then this is what her imaging has to show, right? So what do you think this is? She tells that her primary care doctor has diagnosed her with MS. What do you think? No, I mean, this is a talk on MS, so it looks like benign plaques. We ruled out other things.
Is this with contrast?
This is without contrast. It's a T2 flare imaging. We do, correct, but what is it? Correct, so she does have infratentorial lesions, right? She has one in the midbrain, standing across the midline, posteriorly, anteriorly, left frontal, periventricular, right there, which looks very classic. So what do you call this kind of a patient who has no clinical features, but has radiological features, radiologically isolated syndrome, right? So you can see this is a pretty classic lesion for MS, right? It's a perpendicular lesion like Dawson's fingers that you see. So what do you do for such a patient? Would you want to treat her? Would you want to do something more? She's come to you, and it's not unusual that you would see such a patient in the clinic. I do see this quite often, that they come in. So what would you want to do once you clarified that there is no prior history suggestive of a relapsing?
She doesn't have any
She went for a headache. She had a headache, and that's why her doctor scanned.
follow up in 6 months.
Follow up in 6 months. What else do you think you'd want to do at this point in time? A lumbar puncture might be useful, right? What else would you want to do? Any other imaging? Imaging with contrast might be helpful to see if she does have contrast enhancing lesions. What
But if
else?
She doesn't have symptoms.
Because you're looking for demyelinating etiology here, so you want to see if there's activity because, and I can tell you why in a bit. What other part? Well, you're missing one other part, imaging. NMO you can do for workup, yes, but imaging, you'd want to get C-spine imaging, right? Because the MS does affect the brain, but it does tend to affect the spinal cord as well. So you want to get a C-spine imaging at baseline to see if there is evidence of demyelinating lesions in the spine. Now, in the brain, you can have other differentials. It could be an autoimmune condition like lupus or Sjogren's or NMO sometimes. NMO can cause cortical lesions, although classically it's just optica and myelitis. Also, perhaps at baseline, I would send her to get an eye exam to see that her optic nerve truly is not involved. Okay, and that would help us make this decision. But I agree, if her spinal cord imaging looks okay, I don't see any lesions on there, and if her CSF oligoclonal bands comes back negative, she doesn't have any eye involvement, she would qualify for radiologically isolated syndrome, and I would wait for 6 months before I start her on treatment. Okay. Now, the same patient, she's coming to you now, this time not with headache, but she says, you know, she comes in with a week's worth of numbness on the right side of her body. Okay. And she has this kind of an imaging, and you see an active lesion in the left parietal lobe, enhancing lesion. So what would that put her down as now? So we're talking about definitions here. I just want you to be clear on the definitions before we move on to the medications that we use. What would that put her under? What class we put her under?
I will put in supplemental first.
No, what do you call her? We're not
No,
talking about, is it relapsing remitting yet?
Only one.
What is the other term? One is radiologically isolated syndrome, clinically isolated syndrome, right? So she has one clinical episode. She hasn't had prior episodes suggestive of a relapsing remitting course. She has imaging findings, however, which is consistent with demyelinating process, and she has the one active lesion. Okay.
So why is it called clinical isolated if she has radiological evidence?
Because it's clinically isolated. We're not talking about radiological definition here. Now, they all come under the same spectrum
But we already
of
had
But this
multiple
lady already
sclerosis.
had a radiology show that.
No, we're talking about different
Oh.
case now. She
Oh,
did
I
have,
thought you.
But you're talking about this new case. Also, she has the.
correct, she does have imaging findings, but her clinical presentation is just the one episode that she's had.
Okay.
We're the same patient.
If it still were the same patient, I would still call it a clinically isolated syndrome, because by definition, it is having one episode, one clinical episode of relapse. She hasn't had multiple relapses. So to call it multiple sclerosis, you should have it disseminated in time, which means she has a relapse now, and perhaps 30 days later, perhaps, an imaging finding that shows up, which can be substituted for a clinical relapse. Okay, so this is a clinically isolated syndrome that she has now, and then of course you treat her with Solumetra or whatever that might be. Okay, and say the same patient comes into you, but this time she tells you, yes, actually I lost my vision in my left eye 2 years ago, and we didn't think about it. I think I was diagnosed with optic neuritis at that time. So now you have two clinical events disseminated in time. Right? It could be 2 years ago, it could be 2 months ago, or it could be a month ago. It doesn't have to be. At least 30 days apart is the clinical time that we allow, and we only allow this because it takes that much time for a relapse to recover from. Okay, but it doesn't necessarily have to be. This patient actually had a relapse within about 3 weeks. I put her on a steroid taper, and then she came back between June 22nd, June 9th to July 6th. June 9th was her previous imaging. And July 6th, she had another relapse. So it erstwhile was defined as 30 days, but she clearly had a relapse by that time. So if you have two clearly identifiable clinical events suspicious for a relapse, then you would call it a relapsing remitting MS in the right setting, in the imaging setting that goes here. Okay. Now, who would you put on treatment long term, your disease modifying treatment? Would you put the radiologically isolated syndrome patient on treatment?
It depends on the radiological evidence.
So if the
If
patient,
you're old and new,
yeah, even then you don't. If the radiologically isolated, at least as per current evidence, there's actually a trial going on in the UT Southwestern. Darren Okuda, he was the one who defined radiologically isolated syndrome, and he's the one who's conducting the trial. So right now there is a trial going on to see if we should treat radiologically isolated syndrome patients or not. But as of now, we don't treat them. We just follow them clinically. We follow them radiologically at least once every 6 months, making sure they don't have new symptoms, making sure they don't have new lesions. even if they do have new lesions, we don't quite know what to do with them other than referring them to the trial. So I just send them to whichever center is having a trial locally, so that they could be taking part in it, because that's better than anyway I'm not treating them, right? But clinically isolated syndrome, would you treat or not treat? How would you make that decision if you want to treat or not treat? Is there evidence you think?
If there's new lesion.
No, she already has a clinically isolated syndrome. She's come in with one
If
episode
you have
of
acute demyelinating,
radiological evidence, you mean?
yeah, like if contrast enhancing acute
Do
plate.
you really need it? You don't really need it. So if there's a clinically isolated syndrome and there's imaging evidence to show that there are lesions that are
It
suspicious,
doesn't even need to be new.
it doesn't need to be new. No, it doesn't need to be new. You would go totally by the clinical diagnosis itself, because there is evidence to show that if they have a brain MRI, more than one lesion, which is suspicious for demyelinating disease, the chance of converting into clinically definite MS is over 80%. Okay, and we had discussed this the previous time too, but again, I'm just bringing it back up because you don't deal with it as much, and I would want you to know if they don't have any lesions. Say, for instance, it's an optic neuritis patient, doesn't have any lesions on the brain, doesn't have any lesions on the spinal cord, CSF doesn't show oligoclonal bands. We could afford to hold off on disease modifying treatment. But if it's the same optic neuritis patient who does have one lesion anywhere in the brain or in the spinal cord, or oligoclonal bands are positive, the chances of them developing clinically definite multiple sclerosis over 80%, in which case the risk of leaving them without treatment is much higher, and you'd want to treat them. Okay? So I was going to talk about disease-modifying treatments in multiple sclerosis.
I have a question.
Yes.
I never really understood the McDonald criteria, how you use it clinically.
Okay.
Like the disease in time, disease in space, what does that really matters in our diagnosis?
It matters because you want to show that there is more than one lesion. Sometimes I have patients who don't have any symptoms and I have a single demyelinating lesion. Looks like demyelinating, especially I have some of these patients who have pontine lesions, which I don't know if it is demyelinating or not. And I don't want to treat them because they don't have clinical evidence of disease and they don't have radiological evidence of progressive disease. All the McDonald's criteria 2010 talks about is presence of, you should have two lesions, basically one lesion in each of these 4 places. So 2 out of 4 should be positive. So they should have juxtacortical. So you should have basically the McDonald's 2010. One is on imaging, right? So this imaging time by time when we clinical episodes, two distinct clinical episodes, or you can have one clinical episode. Plus, say the same patient who had the right-sided numbness, she has a left parietal enhancing lesion, and she has a right frontal enhancing lesion. That is an asymptomatic active lesion. That is good enough to say that, again, it's disseminated in time. Okay, so one clinical episode plus one asymptomatic lesion. Active. Not to T2, it should be active. So active will be complex equals GAD plus lesion. Will be enough to qualify for dissemination in time. In the space, what it means is basically in space, sure, on the euro axis. That's what it means. Okay, so in space, we're looking for 4 classic territories. Okay, one of them, which are the classic territories, you know, that MS lesions are there on. Very beneficial. Whereas
Subcortical.
juxtacortical, adjacent to the cortex. Where else? Spinal cord and infratemporal, like brain. Okay, so if you have 2 out of the 4, if you have lesions in 2 out of the 4, you should be able to make a diagnosis of multiple sclerosis.
And you don't
clinically
need-
definite multiple sclerosis.
You don't need to look older than you, they can look the same age.
They can look the same age. So for this one, for dissemination in stage, you don't need to have an active lesion. And for dissemination in time, even if you have two clinically distinct episodes, sometimes it's the line might be very indistinct. Like for instance, a patient tells me I had vertigo for a week 2 months ago. Do I take it? Do I not? In those cases, it's very hard to make that decision. But if it lasted for a week and we didn't have any other reason, I might put it down to being MS, especially if she has poor signs. Okay. And sometimes patients just come with non-indistinct symptoms. Tired all the time, I have pain everywhere. So these are like not very classic MS symptoms or signs, right? So in that case, it becomes dicey. But this is the McDonald's criteria to help you make the diagnosis of MS. And this is still under revision because it's being simplified a little bit more. Okay. Now, when there's only one clinical episode without this symptomatic and active lesion, and when they have these 2 out of 4, you're only meeting one criteria for space, you're not meeting criteria for time, in which case it becomes the clinically isolated syndrome. Okay? And when you don't have any clinical episodes, just the lesions, it becomes radiologically isolated syndrome. Okay? So it's all under one section. You have radiologically isolated syndrome, which then becomes clinically isolated syndrome in some patients. About 35% of patients who have radiologically isolated syndrome want to develop a clinical episode. Of the clinically isolated syndrome, about 80% go on, as long as they have one lesion, they go on to develop clinically definite MS. Clinically definite MS, we have different types. We have the relapsing remitting multiple sclerosis and progressive multiple sclerosis. Progressive, we would have primary progressive multiple sclerosis and secondary progressive multiple sclerosis, and then a part of this relapsing remitting, about 10% stay benign without analysis. Yeah. Majority of the patients, 70 to 85% of the patients are relapsing remitting, about 10% primary progressive multiple sclerosis. So that's all under this spectrum. So as of now, we don't have great data to say whether we should treat these radiologically isolated syndrome patients or not. We just follow them closely. But anybody who has a clinical isolated syndrome and have at least one lesion or oleoform bands present, we want to treat them like clinically definite MS because the earlier you treat, there is data to say that the more of the brain you're preserving. Okay? And that has been shown even with the injectable medications, which have been around now for 20, 25 years, right?
So even though it's
Do you get what the
it's very
definition
clear.
is now?
Yeah.
Okay.
Yeah. So radiological isolated syndrome, you can still call that person MS, right? Even that is still.
I would
part
still
of
call
MS.
it. I would still call it radiologically isolated syndrome because it's still not. It's not under the classification of MS. It's very technical, but if you call them MS, you have to treat them. They are not yet MS because they don't have clinical signs of
So
MS.
you just call radio.
Yeah,
so it's
sometimes
not part of
patients
MS.
have these lesions which look like demyelinating. I've often seen them in the setting of head trauma,
Yeah.
which, I don't know if it's MS not, and they often come to me with it. And we just follow them as long as they don't have clinical worsening objectively. I would not put them on treatment just yet. Okay, and we have to wait on the trial data and see what it shows.
Does the, for the space lesions, does the optic nerve not count as a requirement?
The optic nerve, if there is optic neuritis, that becomes an active lesion. You can use it for making a diagnosis, but it's not typically described under the criteria, under the McDonald's criteria. But if the patient has optic neuritis, they have T2 enhancement of the optic nerve, and there's one other lesion periventricularly, I would use it to help with diagnosis. Okay, so these are the medications that we use for acute treatment. That's prednisone, IVIG, ACTH, and then post 1993 we had a lot of medications available. So of these, you have the first line medications, which are the second line medications. I don't know where my first line went away, but right. The first line medications are the injectable medications, okay, which is Avonex. They're called the BRACE therapy. So BRACE, which is Vitaceron. that's called the brace therapy. So we have butazidone, okay, which is interferon B. Then you have Rebus, interferon.
So for the clinical isolated syndrome, even though it's sensory predominant, it still counts.
Yes. Avonex, which is interferon A intramuscular. We have copaxone, which is lacrymal acetate. We have Stay, which is another form of interferon beta 1. Okay, so we have a lot of the interferon beta 1b, beta 1a, and the glatiramer acetate. This is the brace therapy, which is the injectable treatments that we have available. Okay, so
Why is that?
see, Xtavia is the fifth one. Okay, so it's betaseron, Rebif, Avonex, Copaxone, and Xtavia. So those are the first line treatments, and then you have the oral medications which then became available, which is fingolimod, the trade name is Gilenya, teriflunomide, the trade name is Aubagio, and dimethyl fumarate, which is tefidil. You also have another form of treatment, which is the infusions, Tysabri or natalizumab. So the infusions are mostly antibodies. As you see, they all end with the letter AB. Tysabri has been around at least for the last 10 years now. Lemtrada or alemtuzumab, you can close it. I'll go back to it if I need to. Daclizumab, which is Zinryta, and ocrelizumab ocrevus, which recently got approved for treatment of multiple sclerosis. Ocrelizumab ocrevus. Okay. So the infusions, we tend to use them for the more aggressive multiple sclerosis. Okay. By aggressive, they call the highly active relapsing multiple sclerosis. Okay. And these patients, they tend to have, despite being on a disease modifying agent, if they tend to continue to have active enhancing lesions, if they continue to have relapses, at least 2 relapses in the year, or new brainstem lesion, new spinal cord lesion. Why is brainstem and spinal cord bad? Because there's a lot of fibers that are getting together at the region of the brainstem and the spinal cord. So even if it's a single lesion there, there's long-term prognostic value to it, right? The deficit is much more. The tendency to recover is much less. So if they have any of those, they are called as the more highly active relapsing multiple sclerosis. So those are the patients that I might tend to use the infusions on. Okay. So currently, like I said, you have all of these, the brace therapy that's on one side, novantrone or mitoxantrone used to be used, but we don't use it anymore because of the cardiac side effect. Okay. So novantrone, mitoxantrone. They only ask for, in the right exam, they love to ask about it. I have no idea why. We haven't used it from the time it was approved because it had really bad cardiac side effects. It would cause cardiac failure, irreversible. Okay, so betaseron, Avonex, Copaxone, Rebif are the earlier ones. Xtavia was more recently approved sometime in 2009. Tysabri, like I said, has been around for 10 years. And then you have, of course, the oral therapy started coming into play sometime around 2010. We got the first approval, and then Aubagio and Tefidera pretty quickly. We'll talk about Plegridy shortly. Lemtrada, Zinryta, ocrelizumab, and Tysabri are the infusions. So again, the infusions more recently, except for Tysabri, which has been around for a longer time. Okay, and this is like the bigger picture to tell you that there are so many phase 1 trials ongoing, phase 2 trials, phase 3 trials, and those that are already marketed that are here. But as you can see, there's a lot of phase 1 and 2 trials going on based on interferons, anti-proliferation agents, vaccines for multiple sclerosis, targeted antibodies, which are the the ocrelizumab and alemtuzumab comes under that. The slide is a little old, so some of these are showing as phase 3 trial, but ocrelizumab and alemtuzumab are already marketed. And then immune regulatory medication, and then a lot in the lymphocyte trafficking, which is the basically like the fingolimod type of medication. But there's a lot of research going on in the MS world trying to see which one would be the most, where we could get benefit for patients. This is basically wealth of experience of the different medication, and it goes with the time. So interferons have been around for the longest time. So we have a lot of information, and safety data is really good with these injectables, which is again useful for you when you talk to the patients to say which one you want to offer to them. If they have a more benign type of disease and you want a good safety profile, don't want to expose them to the risk of all the other medications, I might go for the injectables, okay? Because the wealth of data is much more with these as opposed to the oral medications, which we don't really have that much data on. So the challenges that we experience is that it's very complex. Each patient is different. Several drugs are available. The comparison is imperfect because we can't have a trial for every single medication between every single medication. So all you can tell patients is this compared to placebo, this is what the data shows. And there are a few comparison trials which I'll bring up today and show you, which you can then use to say, yes, we compared Aubagio to Avonex, and we see that Aubagio is better than Avonex, and that I can tell you for sure, and I can offer that to you. But it's impossible to have studies that compare each of them. So it's always apples to pears, and I tell patients that's how it is. But based on my experience, this is what might work for you, and that's called shared decision making, because you can't give the patient, here are 10 medications, take your pick. That's not going to work, right? I mean, being on the patient side, we want to think about how many effects and side effects these medications have. Outcomes are changing. We don't have a great algorithm, although right now the ANS has a task force group that's trying to put together an algorithm. An algorithm at some point might come through if we have like a biomarker to help us or something more objective to help us make that decision. But as of now, we don't have. Like for instance, in the oncology world, we go truly by biomarkers. If they have this and this positive, this is what will work for them. Whereas if they have this positive and that negative, that will work for them. But we don't have that kind of a thing with the MS world just yet. Okay. There are a lot of unexplored therapeutic agents, and each individual patient you'd want to adapt to. And of course, insurance drives a lot of this too. Okay. Prognostic indicators, we spoke about this briefly at the previous talk. Younger age, female, white, pure sensory, optic neuritis, quick recovery with longer interval between attacks, no spinal cord, no brainstem, only T2 lesions with little or no atrophy have better outcomes as opposed to older age group, male, African American, motor cerebellar sphincter symptoms. Because again, you're thinking about that cerebellar is, infratentorial sphincter symptoms, probably card, longer recovery from each episode, shorter interval between the episodes, spinal cord involvement, and T1 lesions or black holes. So when I pull up the images, there's something called black hole. Basically, black holes are when you have axonal. So you have demyelination that occurs, and demyelination, the myelin may recover. Okay, there is a chance for the myelin to recover, as opposed to axonal loss, where there will not be a recovery, and that's what leaves the T1 black holes. Okay, so that portends a poorer prognosis because now there is loss of axons, and that's what leads disability for the patient, right? And then, of course, if there's atrophy, it's a worse outcome.
I thought old age of onset is better for instance because they don't have that much time to have a multiple relapse and have a severe outcome.
Not necessarily. Actually, they have a poorer prognosis because they have much less reserve. They have much less tendency to recover from episode 2, especially if it's an older male. They tend to have more the progressive type of multiple sclerosis. The number of relapses may be lesser, but they are probably in the progressive type of disease where there's more of degeneration and less of demyelination, in which case our medications don't work very well either. Okay. So the aim of treatment is making sure the patient is free of relapses, free of progression, disease progression, which we measure in terms of the expanded disability scale. Okay, free of gadolinium lesions and free of T2 lesions. Okay, so basically it's called as no evidence, NEDA is the acronym that's used, basically called no evidence of disease activity, which is our aim. When you talk to the patient, you say, our aim is to make sure that when we get your next imaging, you don't have new lesions, you don't have gadolinium lesions. And I see you at the next time, I'm hoping you don't have any more relapses with this medication and you are not, more disabled as compared to today. So that's what every visit, we go through these motions, not the imaging every time perhaps. Imaging is typically every 6 months, unless I'm following them really closely for more active disease. So the fourth, there's something called NEDA4, which is the fourth criteria that was added, which is no annual brain volume loss more than 0.4%. Now, this is a more difficult criteria to target outside of the research world because our MRIs don't really know how to measure brain volume accurately just yet. Okay. So talking about the first line therapies, as you can see, there are a lot of the first line therapies. The beta 1A subcutaneous, and I am probably open this up so you can see what you're talking about. Okay. So I am once weekly is the Avanex. 1A 3 times a week is the Rebif. 1B is Betaseron, and this is Extavia, which is 1B. And then glatiramer acetate we'll talk about, and then teriflunomide and dimethyl fumarate are the oral medications, which are also used first line. Okay. So briefly, we spoke about the immunology of multiple sclerosis. In a normal individual, the Th1 and the Th2, the helper cells are balanced. In MS, you have a lot more of the Th1 cells which take over and damage the myelin as compared to the Th2 cells, and that's what the treatment is targeting. Okay. Again, these Th1 cells produce the pro-inflammatory cytokines as opposed to Th2 cells which produce the anti-inflammatory cytokines. So the first medication we'll talk about are the interferons. We don't really know how any of these medications really work, but they work. Okay. So when I talk about mechanism, I think it's going to be very sort of superficial when I say it. So their main job is to ensure that your anti-inflammatory cytokines are more and your pro-inflammatory cytokines are less, and that's the mechanism by which it works. It also reduces the inflammatory cell migration across the blood-brain barrier. Okay, so the 5 medications that we spoke about are here, and it's only when you get into practice, I guess, you'll be able to sort of distinguish one versus the other. The most common ones that I use in terms of the interferons are Avanex, Rebif, and Betaseron, depending on what the patient tells me, because the Avanex has once a week dosage, it's intramuscular. The others are all subcutaneous. So depending on patient ability to inject themselves, things like that, and if they tell me once a week is better for me, and of course, if the disease is more sort of low key, I would probably choose this over the others. Okay. Now, there were a lot of trials that looked at it, but in general, if you look at the number, it's 30%, 33, 34. Overall, the one number that I want you to remember is both with the interferons and with glatiramer, there was about a 30% decrease in the relapse rate as compared to placebo. Okay, and that's the number that I want you to remember. That's about 30%, as opposed to some of the oral medications, which is 60 to 70%. Okay. The interferons more recently were, because of the fact that it was 3 times a week and there was strong competition from the oral medications, they decided to change the interferons a little bit and they made it pegylated. Now, have you heard of pegylated medications in other disease forms? Pegylated interferons? Hepatitis, right? So it's the same pegylation that was done for the MS medication too. It primarily prolongs the life of that interferon so that they can inject once every 2 weeks rather than every other day or once a week. And that's the only advantage that this particular formulation provides. There was a study that looked at it, which was the advanced study. Okay. So interferons side effects is something that I'd want you to know, because again, though this has been around for a long time, the 2 main side effects when I talk to patients is monitoring their blood work and flu-like side effects. So interferons can cause a lot of flu-like side effects, can last up to 6 months after starting them on this medication. So and that can be pretty distressing because they feel like, like how you feel when you have flu, pain all over, feverish, not in the mood to do anything. And if you tell them you have to take 3 times a week, that can be a pretty distressing side effect, especially if it's a young patient who's employed, has kids to take care of, kids activities to take care of. That's a big burden, right? So you'd want to think about it, and that can occur in up to 50 to 60% of patients. The other side effects with interferons include depression, caution history of seizures. We always monitor kidney, liver, thyroid functions annually for them, and then of course lymphopenia. It's very common, and up to 5% with grade 3 or 4. So the lymphocytes, I keep a closer watch, but maybe once every 6 months or so. But overall, they're pretty safe, barring these effects. So thyroid, liver, lymphocytes, and fatigue. Okay, how do you minimize fatigue? What would you tell the patient to do to minimize this flu-like symptom? What would you do? You can pre-medicate them. Okay, so oftentimes we tell them you can pre-medicate with either aspirin or Motrin and try to take it during bedtime. so that they can sleep it off and majority of the effect goes away in their sleep and they wake up feeling a little bit more refreshed. And that seems to help a lot of the patients. Okay, so we can pre-medicate them with Motrin and try to take it at bedtime. Injection site reactions are not as common with the interferons. The next medication that we're talking about today is glatiramer acetate or Copaxone, which is also a very commonly used first-line medication. Okay, the mechanism is that basically glatiramer itself, the molecule, goes like an antigen-presenting cell. It goes and attaches, presents like an antigen, and it modulates it such a way that the PH2 takes over the DH1. Okay, that's the main mechanism by which it works. Again, glatiramer number is 30% as compared to placebo. There was reduction in MRI lesions, and the more recently there was something called as GALA trial, because prior to 2013, Copaxone had to be injected every day. Okay, which is still quite a bit if you think about it. If you put yourself in the patient's place. I mean, I know I'm pretty poor even with taking antibiotics if it's for a week. By the time it's day 4 or 5, I'm pretty sure I miss a few doses here and there. So think about these patients. It's a chronic disease. They have to inject themselves every single day. So that was hard. So then there was a study that initially looked, it's called the Glacier, which compared the glatiramer 20 and 40, and they found that 40 worked really well. And then the 40 was done every other day as compared to placebo, and the 40 seemed to work very well. So over the last 4 years, Copaxone is now available in 3 times a week formulation, which works well for patients and works well for me, because when I'm offering the patient everyday injection versus a medication that has flu-like side effects, it's difficult for them to make that decision. At least now one round is evened out because it's 3 times a week for both these medications, and then I can talk to them about it. What about the side effects of Copaxone? You know of any? Not for Copaxone. Copaxone, it's primarily 2 things. It's injection site reactions and a transient chest tightness that occurs. So they can have anaphylactoid reactions. So the only 2 things that I tell patients is when they get the initial injection, they might have a chest tightness that occurs transiently. And then cutaneous reactions can actually be pretty prominent with these patients. Injection site reaction of up to 40%. So that's a pretty big number. So we normally ask them to rotate their sites. So it's 4 different sites, or sometimes even into the abdomen because it's subcutaneous. I recently saw a patient in the clinic. She wasn't diabetic, not immunocompromised, but she was taking Copaxone, and for some reason she developed a big subcutaneous abscess, and that was from this injection, from the Copaxone injections. I don't quite know what caused her to have it, though she was rotating sites, but it was a pretty significant. I had to report it to the company and had to take her off the Copaxone and consider an oral medication after her. But it can cause pretty significant cutaneous reactions. Okay? But otherwise, if you see, the rest of the boxes are clean. You don't need to monitor blood work for it. You don't need to monitor liver. You don't need to monitor lymphocytes. None of that. No thyroid. So that way, it's a pretty clean medication. No infections. None of that. Okay. So that way, if I feel like a patient has sensory symptoms, has 1 lesion on the brain, doing otherwise pretty well, wants to get pregnant, young female, Copaxone is a good choice because it's still a category B for pregnancy. None of the other medications are category B. Okay. So moving on to clinically isolated syndrome, are there studies that looked at it? There were multiple studies that looked at whether medication would work for clinically isolated syndrome. So this is Copaxone. So Copaxone study did show that there was a benefit with Copaxone. Conversion risk was reduced at 2 years. All of these looked at a 2-year conversion risk, and all of them were positive. So all of the interferons, interferon beta 1b, that is beta-seron, 1a muscular, which is Avonex, which is a CHAMPS trial, then 1a subcutaneous, which was the Rebif and Rebif. So 2 trials for Rebif, 1 for Avonex, 1 for beta-seron, and 1 for Copaxone. So that tells you that clinically isolated syndrome, there are multiple studies, and these are old trials. These are from 2001, 2006, 2009, and all of the studies showed that you must treat clinically isolated syndrome so that they don't develop clinically definite MS. So when I have to offer a patient medication for clinically isolated syndrome, this is the data that I can use to say, yes, we looked at follow-up natural history data, and we saw that 80% convert to clinically definite MS. And we looked at this data to say that if we use any of these injectable medications, the chance of conversion at 2 years is much lower compared to placebo or following the natural history, right? There was also, I put this only because I didn't have the time to change it. There was one oral medication that looked at it, which is Aubagio. And Aubagio was compared to placebo and clinically isolated syndrome, and we did see that there was a benefit. So that's one oral medication that I offer for CIS patients in addition to the injectable medications because there's trial data.
How much reduce? How much do you have to?
Just about, I think,
30%.
25%. Yeah. Okay. Conversion risk was 25% with Glatiramer as opposed to 43% with placebo. 34% versus 45% with placebo. So the risk is less, but still, it minimized that risk. It was significant. Then earlier treatment is more effective treatment is the other thing that we looked at. And then some of the direct comparison trials. So these are used more for talking to patients, just because if I have to tell them, is Avonex better for you or Copaxone better for you, or, so I can use this, or if I have to fight with it. It's more to fight with an insurance company. They're not giving me a medication than anything else. But there are trials that have looked at it. Primarily, between Avonex seems to be the weakest interferon, Betaseron and Rebif are comparable. So if you look at, this is Avonex, the only intramuscular is Avonex, okay? And this is Rebif versus Extavia, I think. And they looked at it. There was a significant difference with the subcutaneous injection as compared to the intramuscular. Glatiramer and interferon were similar in efficacy. So overall, the injectables are comparable, and we could use one versus the other depending on the patient's comorbidity. Like, for instance, if they have depression, I would prefer Copaxone over interferons because interferons do cause depression as opposed to Copaxone. So something like that. Okay? And these are the safety profiles. We'll just move on to questions. Oh, we have a couple more slides. So this is teriflunomide, which is the first-line oral medication, also known as Aubagio. The parent medication was leflunomide. Have you heard of leflunomide? Rheumatoid arthritis, correct. So that was the parent compound, and this is derived from leflunomide. And there were studies that looked at teriflunomide in those patients, and we saw that it basically works on the rapidly proliferating lymphocytes, which are the active lymphocytes, and it's basically the dihydroorotate dehydrogenase dependent pyrimidine pathway that is interfered with. But the other salvage pathway, which is your resting homeostatic lymphocytes, are not affected. So those can carry on. So that's the way it works for multiple sclerosis. There were two trials that looked at it, Temso and Tower. One was against to look at the dosing, and the one was against, both of them were against placebo. Yeah, placebo versus 14 milligrams. So currently, the approved medication is 14 milligram. However, the one thing you should remember with this is that Aubagio or teriflunomide still has just a 30% relapse rate reduction as compared to placebo. Okay, which is comparable to what the oral medications has. Okay, that's a number that I again often use because in terms of efficacy, though it's an oral medication, efficacy-wise, it still compares to, you're not comparing it directly to an injectable medication, but if you compare to placebo, it's roughly about 30% decrease in the relapse rate reduction. Okay,
And this is still injected.
no, this is oral. This is now we moved on to the oral medication. We talked about the interferons, talked about Copaxone. Interferons had Avonex, Betaseron, Extavia, and the pegylated interferon as well. Copaxone is Lacrimar by itself. This is now an oral medication. This is also first line. This is still a first-line medication. Okay, it's called Aubagio, and the generic name is teriflunomide.
And they all cross blood-brain barrier.
They do, yeah. Okay, so the one other data that teriflunomide showed after the initial study was that it does decrease the percentage change in brain volume. So there are two medications that do that. One is fingolimod or Gilenya, and one is the Aubagio. Okay, studies have shown that there is a decrease in the rate. Also, this is the one other medication that I told you, other than the injectable medication, this is the one oral medication that has shown that conversion from CIS to CDMS decreased with an oral medication. It doesn't mean that the others don't, we just don't have a study. Okay? And this compared to Avonex and showed that this did better than Avonex in a head-to-head study. This is some of the other teriflunomide studies. What about the side effect profile with teriflunomide? So teriflunomide does have a big black box warning in terms of liver functions. So it can cause fulminant liver failure. So we check liver functions every month for the first 6 months for our patients. Okay. It can also cause lymphopenia. It's about 12% grade 2 or worse. So we follow blood counts every 3 months from when we initiate them on the medication. But the liver functions have to be done every month for the first 6 months. The one big thing with teriflunomide is thermogenicity. it's a category X with pregnancy. Okay, so if they are on it, so US black box is for hepatotoxicity and teratogenicity risk. So those are the two main side effects. So not just for the female, also for the male, because it gets excreted into the semen. So that's a category X. And so even if you're thinking about a young male, you would have to consider that they have to use some kind of an effective contraception. Okay. The good thing about teriflunomide is that you can use a medication. You can use basically cholestyramine to wash it out, and it gets washed out within 9 days to bring it down to a level which is almost undetectable in the serum. But it takes that much time. And that's why we have a pregnancy registry, which really hasn't shown that much in the way of harmful effects as long as you wash it out right away. I take caution though when I give this to my patients, especially if I feel like they're not going to be compliant with contraception, things like that.
And then they have less relapse rate during pregnancy.
Overall pregnancy, yes, they do.
So you can lower it.
You take them off it. You take them off it. Yeah, it's a black box. I wouldn't plan a pregnancy if they're on the medication. So normally I would tell them, let me know if you're planning pregnancy so we can get you on it. I always make sure, especially with infusions, I get a urine blood check because the infusions are typically once every 6 months. Make sure they get a urine HCG to make sure they're not pregnant before they get the next infusion.
So if patients are on this and they want to be pregnant, would you take them off this and change to a Piramer, or you will just?
Pregnancy is a different talk altogether. They would have to be stable for at least 2 years before I decide to take them off it.
Okay.
And then you can take them off it and let them know to plan pregnancy. You can take them off, and within a month of taking off this particular medication, they can get planning for the pregnancy, keep them on prenatal vitamins, folate, and plan for the pregnancy. Because though Latimer is a category B, none of the OBs are comfortable, and somehow in the real world, none of the MS physicians want to keep them on Latimer either. But pregnancy by itself is an immune tolerant state, so they tend not to have relapses during the pregnancy. Okay, which is a good thing for us, right? So some of the side effects with teriflunomide, it can cause hair loss, which is again an important side effect you want to tell patients. It's very transient. Within 3 months, it starts coming back again. But when you start them on it, they will have pretty significant hair loss. Also, it can cause a bump in blood pressure. So you want to measure their blood pressure every time they come in because cancer can cause a bump in blood pressure. Another infection risk. Infection risk with teriflunomide is that it can cause tuberculosis. So you want to make sure that they have their TB negative. You get the quantiferon test and make sure that they're negative. Okay. So those are the side effects with respect to teriflunomide. A couple more new ones that came up were Stevens-Johnson syndrome. It just got into the PI last year, and interstitial lung disease in a small proportion of patients. The last first-line medication we'll talk about is PG12 or dimethyl fumarate or Tecfidera. If you've heard the brand name Tecfidera. Okay. This works again basically by a complicated mechanism. The mechanism is to decrease your to increase your pro-inflammatory and decrease your anti-inflammatory. Okay. There were 2 trials that looked at it to establish the dose. So the dose that was we use now is 240 milligrams twice a day. Okay. However, if you look at the relapse rate reduction, this was about 50% reduction compared to placebo, and this was the BID dose versus TID dose versus Copaxone versus placebo. The BID dose showed 44%, TID dose shows 51%, as opposed to Copaxone, which showed 30% compared to placebo. Okay, so this did compare it to placebo. So the previous medication was compared to Avonex, which is a good one for you to use to tell patients. And this used Copaxone to compare, which is again a good one when you're talking to patients oral versus injectable. Okay. So, but you can see that the relapse rate reduction was about 40 to 45% in patients compared to the Copaxone itself, which is a bigger number as compared to the 30% that we've been talking about so far. Okay. Lymphopenia was found in the post-hoc analysis and the post-marketing phase. Lymphopenia was a big side effect with this medication. So we were talking about flushing. Flushing is a common side effect with this medication. Diarrhea is a common side with this medication. Correct. But lymphopenia is one of the big side effects with this medication. And we target lymphocytes to over 500 for 6 months. If they don't stay over 500 for more than 6 months, or if they're under 500 for more than 6 months, you'd want to take them off the medication, especially if they're JC positive. JC virus is a virus that can cause this infection called PML. And there are 4 cases reported so far. There are about 270,000 patients on this medication, but there are 4 cases. In all of the 4 cases, lymphopenia was closely related in addition to the JC virus positive. JC can be positive in up to 50% of the MS population, and the risk of transformation is 50% every year. It is transmitted via the respiratory tract as well as via urine. Okay, so it's possible that somebody who's negative can turn positive. So again, that's something that I follow closely. Other than flushing and diarrhea, you want to keep a watch on their kidney and their liver functions to make sure that it stays stable. Like for instance, recently I had a patient who had hepatitis C. He was treated with the medication, and we had to decide. He also had, oh no, not hepatitis, but ulcerative colitis, in addition to the MS that was going on. So this is one of the medications I believe that are being studied. I'm sorry, I'm thinking, you know what? Leave it. Dimethylfumarate, not dimethylfumarate, this Gilenya. We're not talking about Gilenya just yet. Okay, but monitor renal and liver function for this patient. We'll move on to the questions.
Sorry, that one is reduced 50%.
45 to 50%. Yes.
For relapse.
Yes. I did want to ask you questions, but we don't have time. It's 1 o'clock. So I don't know if you want me to just go through this in your video, or we can go through it the next time. We can start off with it the next time, and then move on to the next one. So it'll be like a revision.
Why don't you just click through it?
We can do it next because I want to do the next talk within the next few days, so that we can continue. Then we can start with this. Okay, let's do that because I don't want to go on. You know, I don't know how many of you are in clinic today. You're in clinic. What's that?
Oh, no.
I said, stop.